I read the citation.
Okay. I'm coming, sir. Let me just.
She is a fellow of the National Postgraduate Medical College of Nigeria and the International Council of Ophthalmologists. She had her subspecialty training in oculoplasty, orbit, and ocular oncology at the prestigious LV Prasad Eye Institute, Hyderabad, India, sponsored by the Commonwealth Eye Health Consortium and the International Ophthalmological Fellowship Foundation. She co-founded the Department of Ophthalmology at the University of Medical Sciences Teaching Hospital Complex, Ondo, Nigeria, formerly Ondo State Trauma and Surgical Center, Ondo. She also established and currently heads the Oculoplastics, Orbit, and Ocular Oncology Unit of the Department of Ophthalmology, OAU Teaching Hospitals Complex, Ile-Ife, Nigeria. She is the General Secretary of the Ophthalmic Plastic Surgery Association of Nigeria. Her work and her research are focused on improving the awareness of ocular and orbital disorders, including eye cancers, and improving functional and aesthetic outcomes post-treatment. She had played a major role in more than 40 initiatives focused on community service, providing free ophthalmology consultations, spectacles, cataract surgery, and pterygium surgery to people in impoverished communities across Nigeria. Ladies and gentlemen, please meet Dr. Adewara, Dr. Obalojiko Adewara. Please, you have the floor now. You can go ahead, Dr. Adewara.
Good evening, everyone. Thank you so much, sir. Thank you to all the people who have joined. Good evening to our respected elders, senior colleagues, and members of the Society for the Study of Pain in Nigeria. I want to thank you for the opportunity to present at this webinar, and also to thank my Oga, Dr. Lateju, who invited me personally. Then also, please permit me to acknowledge the presence of my head of department, who was particularly interested in attending this webinar, Professor Benny Sadibengbe. Thank you so much. So I'll be discussing ophthalmic pain today and hoping not to go too deep into ophthalmology. I hope I'm audible.
Yes.
Yes,
Okay.
you are.
Thank you so much. So I'll be discussing it under this outline: introduction, types of ophthalmic pain, anatomy, physiology, causes, and then I'll briefly touch on ophthalmic anesthesia. Ophthalmic pain is also known as eye pain or ophthalmalgia, and it is a complex symptom with various underlying causes. It can also be the first sign of an ophthalmic emergency. Patients with ophthalmic pain associated with vision loss in particular should be referred to ophthalmologists immediately. So it can present from pain in the eyelid and also ocular pain, which is pain originating from surface structures of the eye, such as the cornea, the conjunctiva, and the sclera. Then it can also originate from the orbit, which includes deeper structures within the eye socket, such as muscles, nerves, and blood vessels. So just to go through brief anatomy, the upper eyelid, I don't know if my cursor is visible.
Yes.
Okay, thank you. So this is the upper eyelid, the lower eyelid, and then this white part is covered by a translucent structure called the conjunctiva, and underneath the sclera, which is the white part that is seen through the translucent structure, then there's a transparent structure overlying this brownish area. This brownish part is called the iris, and there's an aperture within that iris, which is known as the pupil, and that is what transmits light rays into the eye. So between the transparent structure and the brown structure, which you can see in this other picture, is the transparent structure is what we call the cornea. And then this is the iris over here. And that space between the cornea and the iris is called the anterior chamber. Then we have the lens posteriorly, and then the vitreous in the posterior segment. And then at the back here, we have the optic nerve. So the iris, the ciliary body here, and this middle layer, the choroid, are pigmented structures in the eye, and they are collectively called uveal tissue. Then this slide is just showing the orbit, which is a concave cavity that houses the eyeball. It also contains extraocular muscles, orbital fats, blood vessels, and nerves, and it is made up of bones. So that is what we call the orbit. So pain, the pain we feel in the eye, there are pain receptors located in the cornea and conjunctiva, and these are stimulated by injury, infection, or inflammation, and they send pain signals to the brain. It can also be caused by inflammation that causes swelling, redness, increasing pressure and pain in the affected area. And then also the trigeminal nerve supplies sensation to the face and eyes and plays a crucial role in transmitting pain signals from the eye to the brain. So briefly, when taking a history, the patients will mainly complain about pain, which they can describe in different ways, like eye ache, eye strain. It could be dull, it could be sharp, it could be described as heaviness or headache around the eye. They could also say they have pain on eye movements or it is tender when touched. But pain associated with eye movements could suggest inflammation of the sclera, which is scleritis, or inflammation of the optic nerve, which is optic neuritis, or infection of the orbit, which is orbital cellulitis, infection of the orbital tissues. Then pain can be associated with changes in vision. And as I said earlier, when there's vision loss, patients should be referred to the ophthalmologist immediately. Can also be foreign body sensation, associated redness, especially when there's inflammation, and then associated discharge, particularly when there is infection. It could also be associated with photophobia, which is sensitivity to light. And this is a sign of corneal involvement or involvement of uveal tissues or inflammation of the uveal tissue. It could also be present when patients experience migraine headaches. Then when they present with headache, it's important to think about acute angle closure glaucoma. That's when there's elevation of the intraocular pressure, and then scleritis, inflammation of the sclera, cluster headaches, and also migraines. It's also important when trying to find out the etiology to ask for a history of trauma or a history of surgery or presence of systemic disease. Then when examining the patient, it's important to do a visual acuity assessment. As I said, changes in vision are very important in patients that present with pain. And you can do a quick examination with a torchlight as well as a slit lamp biomicroscope. And this is used to examine the eyelids, the conjunctiva, sclera, cornea, which are the surface structures I alluded to earlier. Then also it's important to look at the pupil, the reactivity of the pupil, the anterior chamber, if it is visible, if it is deep, if it is clear. Then iris structures, the lens, and also the fundus, which is the posterior part of the eye. Then because the cornea is one of the commonest parts that presents with pain, we have what we call fluorescein dye, which we use to stain the cornea, and any injuries on the cornea or defects will pick up this stain. And this is part of one of the important examinations that we should do. And then the causes of ophthalmic pain are commonly associated with elevation in intraocular pressure. So it's important to measure this, which is also known as tonometry. Then in cases of infection, we need to take samples for microbiology, culture, and sensitivity. And then especially in orbital pain, we may need to do radiological imaging. So for testing distance and near vision, I put these charts here just so that you can see how we assess. So the Snelling chart on the left is used to assess distant vision, 6-5 vision at the bottom here. These smallest figures are usually good vision. while as the vision is reducing, it goes up. Anything worse than 618 is poor vision, and the patient should be referred to an ophthalmologist. Then the near chart, it looks somehow like this. This is assessed at 30 meters, while the distant vision is assessed at 6 feet or 20 meters. So if they're able to read the smallest print, which is N5, then the vision is good. And then this is just a picture of the pen touch I discussed, which is used for examining the external structures. And then this is what the slit lamp microscope looks like, which is used for to see a magnified view of the eye structures. Patient sits directly opposite to the examiner, and the examiner looks through the eyepiece to examine the ocular structures. So quickly going into the causes of ophthalmic pain. I'm starting with the eyelids, and this can be caused by eyelid malpositions. And I put pictures so that what I'm describing will not be too abstract. So here we have a case of ectropion, which is outward turning of the eyelid. So it can happen to any of the eyelids, but in this particular case, it is the lower eyelid. And this can result in corneal exposure and damage to the cornea, which presents with pain. And it is treated surgically, which is called ectropion repair. While the opposite is entropion. And when there is inward turning of the eyelid, it can happen to either the upper eyelid or the lower eyelid, but it is more common in the upper eyelid. And when there is inward turning, the lashes begin to rub on the cornea. The cornea is this particular area here, and compared to here where it is quite clear, you can see that this cornea is already being damaged by these lashes, and it's very painful. And this is also treated by surgical correction, which is entropion repair. And when lashes are rubbing on the cornea like this, it's called trichiasis. Then we could also have inflammation of the eyelid or infection. When the eyelid is inflamed or infected, it's called blepharitis. The treatment is basically warm compress and antibiotics, usually associated with redness, but they don't usually have so much vision loss in blepharitis. And then also it could be due to trauma. Of course, they will feel pain when the eye is traumatized. Here we just do a lid repair. And of course, prophylaxis is to wear safety goggles to prevent or spectacles to prevent such trauma. Then you could also have pain from eyelid swellings. Here there is inflamed nodule, which is called a stye, and is due to infection of the hair bulb, and is treated with systemic antibiotics. This is what it looks like with the eye closed, and this is what it looks like with the eye open. It could also be called an external nodulium. And then we could also have foreign body or foreign objects in the eye, and this can be very painful. And these are when objects are stuck in the eye. Examples could be dust, debris, eyelash, insect cusps. Insect cusps are quite common, especially in Okada riders, because of the wind blowing into their eyes, and then it gets stuck either on the cornea or on the conjunctiva underneath the eyelid. This is called the tarsal plate. And then we have this is an insect cusp. That's part of the body of the insect. It's stuck here on the tarsal plate, and when the eye is closed, you can see how it is damaging the cornea, causing friction. And then this dye, this orange dye, is the fluorescein dye I was talking about. And when there is damage to the cornea, it's seen as green discoloration. So the damaged part of the cornea has picked up the dye and appears green, while these parts are not damaged and appear clear. So usually it tells you that there is a foreign body. So you may not initially see the foreign body, and that's why you have to invert the upper lid with a cutting tip. And then you can now use a cutting tip to remove the foreign body, but sometimes they get so embedded even on the cornea, and you need to use a needle tip to remove it. But such patients, as I said earlier, should be referred to the ophthalmologist. They present with irritation, discomfort, redness, watering, and of course, pain. It is very painful. And then there's also conjunctivitis, which is inflammation of the conjunctiva. This could be due to allergies. It could also be due to infections from viruses and bacteria. They present with discomfort, foreign body sensation, redness. In allergies, you have associated itching, which we treat with antihistamines and mast cell stabilizers. But in infection, they usually present with discharge, eye discharge, which you can see some of it here, and matting of the eyelids, especially on waking up in the morning. In such cases, you may want to take a culture, especially for microscopy, culture and sensitivity, especially when it's severe. And usually we treat with frequent topical broad spectrum antibiotics. We could also have inflammation of the episclera, which is the tissue just uppermost part of the scleral layer. Is usually acute and it could also be recurrent. It causes discomfort and redness. Usually does not present with visual loss. It can be localized or diffuse. And it could also have underlying systemic disorders like autoimmune diseases, usually treated with analgesics, artificial tears, in severe cases, corticosteroids. Such patients should be referred to the ophthalmologist, and it is actually quite painful. Then you could also have scleritis, which is inflammation of the sclera. The pain can radiate to the jaw or the forehead, and it usually presents as a severe boring pain that could awake the patient from sleep. It's also worsened on eye movement. It can be focal or diffuse and presents with photophobia. And what gives it away is this bluish discoloration, which can be seen here due to the stretching of the sclera and exposure of the underlying pigmented choroid tissue. It could be associated with autoimmune diseases, and treatment is topical NSAIDs, but such patients should be referred to the ophthalmologist. Then infective keratitis is actually quite common. It can be secondary to foreign body which causes an ulcer, and then the cornea gets infected. In this case, we have a corneal ulcer here with an abscess, and then you can see hypopion, which is just pus in the anterior chamber. The cornea is opacified, and this is usually very painful. It's associated with redness, eye discharge, and this is a common cause of reduced vision. So this patient should be referred urgently to the ophthalmologist. We usually treat with broad spectrum antibiotics, systemic and topical. And then this corneal abrasion, this is this greenish color shows that the cornea is damaged and is picking up fluorescein dye. And because of this pattern, this linear pattern, it shows that there is a foreign body somewhere. So it's important to vet the eyelids and look for the foreign body, and it's due to scratches on the surface. It's very painful, presents with redness and maybe mild reduction in vision. It's treated with broad spectrum antibiotics, but such patients should be referred for foreign body. Then we also have what we call dry eye syndrome. In this situation, you have insufficient tear production or poor tear quality, which leads to dryness, irritation, and pain. And it can also cause damage to the cornea, especially because of the dryness. The cornea is supposed to be wet all the time by tears, but due to the poor quality or the reduced production, you have areas which become damaged and pick up the fluorescein stain. So this, usually once the cornea is damaged, it's very painful and it can appear like this. Sometimes they have mild redness. The vision loss is not marked. It's not usually marked. We usually treat them with artificial tears, warm compress, and in severe cases, we even need to put pontal plugs. So such patients need to be referred to the ophthalmologist, because it's also a bit challenging to diagnose because they present with atypical symptoms. Then you can also have chemical eye injury from alkali or acid. Usually it's very painful. In mild cases, it presents with redness, but in a severe case like this part is red. So this part is not as damaged as this white part. This is actually ischemia. So in severe cases, it actually presents with a white eye, while in milder cases, it presents with a lot of redness, and you can see that the cornea is damaged and picking up the green fluorescein dye. It's very important to immediately irrigate the eye profusely with normal saline or any source of clean water available, depending on where you find yourself. It's very important to refer this patient to ophthalmologist because it can easily lead to blindness. I usually treat artificial tears, intraocular pressure control, and prophylactic antibiotics and some other medications. Then you can also have acute angle closure glaucoma causing severe pain. And this is due to a sudden increase in intraocular pressure that causes pain, redness, and vision loss, headache, and nausea. If the intraocular pressure is not brought down quickly, this patient can go blind. They present with redness, as you can see here, and then the cornea is also cloudy. So it's an ophthalmic emergency, and we usually treat with systemic and topical anti-glaucoma drugs. Then inflammation of the pigmented layer of the eye is called uveitis. Anterior uveitis is very painful and usually involves inflammation of the anterior uveal tissues, such as the iris or the ciliary body. And they present with keratic precipitates, which are collections of white blood cells deposits on the cornea, which are these discrete deposits, these hypopigmented. They are called keratic precipitates. It causes significant pain, photophobia, and vision loss. So these patients should be referred to the ophthalmologist immediately. Can be due to infection, injury, or autoimmune disorders. We usually treat with steroids, intraocular pressure lowering drugs, and we usually do a systemic workup for secondary systemic causes. Then we also have endophthalmitis. This is a blinding condition. It's an ophthalmic emergency. It presents with severe pain. It presents with redness and severe loss in vision. You can see that there is some pus in the anterior chamber here, and the cornea is already looking cloudy. So they usually have marked reduction in vision. It can be due to infection, which could be post-surgical or endogenous etiology. And when we usually do a vitreous tap for microscopic culture and sensitivity, we give intraocular antibiotics, cycloplegics, anti-glaucoma, and in some cases, we have to do a vitrectomy to remove the vitreous. But patients have to present early, if not, the prognosis for vision is very poor. Then we can also have causes that arise in the orbit. For example, optic cellulitis is quite common in our environment, and this is how the eye looks. Is infection of the tissues around the eye socket. There is usually extraocular muscle restriction or pain on eye movement in early stages. There is swelling, eyelid swelling. There is proptosis, which is anterior protrusion of the eyeball. And there is ptosis. You can see that this eye is drooping compared to the left eye. It could be associated with paranasal sinusitis or infection from the regional structures. Such patients should be referred to ophthalmologists immediately. Usually treat with intravenous broad spectrum antibiotics and some other medications as well. They usually could present with vision loss, marked vision loss as well, especially in severe cases. So there are some other causes of ophthalmic pain. These include eye strain to prolonged visual tasks. It could also be due to improper eye alignment, which is like strabismus, or uncorrected refractive errors. Those are patients that need glasses to see clearly. Associated with discomfort, blood vision, and headaches. So of course, patients that have refractive errors will receive spectacles prescription. But people with poor alignment may also need surgery. And then there's a 20-20-20 rule where every 20 minutes, you can look 20 feet away for at least 20 seconds. That will give the eye some time to rest and adjust. Then you can also have optic neuritis, which is inflammation of the optic nerve. And this could be associated with multiple sclerosis, leading to pain and vision changes. And such patients should be referred to the ophthalmologist and the neurologist as well. Orbital trauma caused by orbital hemorrhage from trauma, which is bleeding into the orbit, can also present with pain, proptosis, redness, and vision loss. And such patients, the pressure is quite markedly elevated, and such patients can go blind if not treated immediately. And we also have orbital fractures, also due to trauma, which could present with pain and enophthalmos, which is backward sunken eyeball. And they also present with redness and poor eye movement. Then you can also have tension headaches, migraines, and cluster headaches that cause eye pain. And then there's also eye pain from post-surgical in patients who have had ophthalmic surgery. Usually treat with systemic analgesics depending on the severity of the pain. And then sometimes sinusitis, that's inflammation of the sinuses, can also lead to referred pain to the eyes. So in summary, when you have a history of contact lens use, usually contact lens can be used in place of spectacles, and is usually placed on the cornea. So in such cases, the possible causes of such pain could be corneal abrasion, keratitis, or infective conjunctivitis. And then when there's decreased vision, you should think about optic neuritis, scleritis, keratitis, uveitis, acute angle closure glaucoma, and cellulitis. Then foreign body sensation, when patients say that they have feeling as if there's stones in the eye or a pricking sensation, and also think about corneal abrasion, dry eye syndrome, keratitis, or a retained foreign body. Headache, as I said earlier, is associated with acute angle closure glaucoma, scleritis, cluster headache, migraine. And photophobia, which is sensitivity to light, is usually common when there's inflammation of the uveal tissue or the cornea. So it could be keratitis, uveitis, corneal abrasion, but also be associated in patients with migraine, headache, and acute angle closure glaucoma. But when the pain is described as stabbing or boring, think of scleritis or cluster headache. And then systemic inflammatory or autoimmune disease usually presents with scleritis, uveitis, or optic neuritis. So in such patients, you want to do a systemic workup. Then when examining the patient and you examine the conjunctiva and there is redness, I mean, it can be associated with any of these conditions. Then eye swelling, like I showed you earlier, stye or hordeolum. Then orbital cellulitis, then preceptal cellulitis. Preceptal cellulitis is when the anterior part of the orbit is inflamed. Then increased intraocular pressure, think about acute angle closure glaucoma, and this pressure is usually markedly elevated, could be as high as 50 millimeters of mercury. So it has to be brought down as an emergency. Pain on extraocular muscle movement, think about optic neuritis, orbital cellulitis, scleritis, acute angle closure glaucoma. And then when there is abnormal pupil reaction, which we call a relative apparent pupillary defect, it means that the optic nerve is involved. So we think of optic neuritis, that's almost like a cranial nerve 2 pulsing. And then of course, when the cornea is picking up fluorescein stain, think of an abrasion or an infection or an ulcer. So I've discussed most of this earlier, so this is just a summary of all I've been saying. Then just to talk briefly about ophthalmic anesthesia, especially in children or people that cannot cooperate with local anesthesia or regional anesthesia, we usually give general anesthesia, and of course this also comprises analgesics. But in patients, like for example, particularly in ophthalmic plastic surgery, we make use of a lot of nerve blocks. Some of these nerve blocks are what I've depicted using these pictures. So I'll start with the one on the left. So this, so usually what we use is xylocaine with adrenaline combination. And we usually give peribulbar blocks, which is about 5 mils, into the orbit. So when peribulbar is just around the eyeball, near the insertion of the muscles, so we inject it through the skin or through the conjunctiva into the orbit. Then we can also use topical eye drops for anesthesia. For example, when we want to remove a foreign body from the cornea, we usually apply topical eye drops, which we call tetracaine or prilocaine. Tetracaine eye drops. So this anesthetizes the cornea and then makes the removal of the foreign body more comfortable for the patient. Then you can also give a peribulbar block inferiorly. Then you can give a retrobulbar block, which is behind the eyeball. So a retrobulbar block is given behind the eyeball, a peribulbar block is given around the eyeball, and it's still the same xylocaine with adrenaline combination that we use. Then we can give a subtenon block. A subtenon block is given with a cannula, so it's actually safer than the peribulbar and retrobulbar blocks, which are given with needles. So the subtenon block is given between the tenons layer and the eyeball. And these are common anesthesias that are used for cataract surgery, which is one of the commonest surgeries in ophthalmology. Then for ophthalmic plastic surgeries, which are surgeries of the orbit and the ocular adnexia, that's the skin around the upper lids, the lower lids, and the skin generally around the eye, we use any of these blocks. So this infraorbital block, particularly if you are working on the lower lid, then the supraorbital block, we also use xylocaine and adrenaline. But usually once the surgeries are extending beyond 1 hour, you want to combine with bupivacaine, plain bupivacaine, and usually give it in ratio 2:3, where bupivacaine is 3 mils and xylocaine is 2. Then we also have the supratrochlear block, infratrochlear block, zygomaticofacial nerve block, and the lacrimal nerve block. So these blocks, these supraorbital, all these blocks on this side are common when we're doing dacrorhinocystostomies, and then when we are working on the upper lid and the lower lid. Also, when we are working on the lid, we want to immobilize the upper and lower lid. Then also when we are doing eyeball ocular surgeries like cataract and pterygium. So you want to give a facial block. So there's a Nadbath block, the O'Brien block, but the commonest one we use is the modified Van Lint block. And we use xylocaine mixed with adrenaline, where we inject it into the angle of the, around here, one centimeter from the lateral canthus, and then inject upward and downward. And that usually paralyzes the facial nerve, and then so that the patient doesn't blink during surgery, because that could lead to complications. So these are the common blocks that we use. We also use topical eye drops, as I said, and we use general anesthesia for people who cannot cooperate with local anesthesia, like children. And then we also give local infiltration. For example, if we are doing a pterygium surgery, we'll just locally infiltrate the tissue that we want to remove. But sometimes we do combination of blocks. Like we can give facial block with peribulbar block with topical block, or infraorbital block with local infiltration, peribulbar block with local infiltration. So we give different combinations in a way that to make sure that the patient doesn't feel pain throughout the surgery. And as I said, if for longer surgeries, we would also combine with bupivacaine. So in conclusion, ophthalmic pain is a common presentation of eye disorders. It can manifest in various forms such as discomfort, irritation, ocular pain, orbital pain, and headache. Etiology could be ocular, adnexal, orbital, or even due to systemic conditions. But as I've said throughout the presentation, most importantly, ophthalmic pain associated with redness, photophobia, and vision loss should be referred to the ophthalmologist immediately. And we have an acronym, RSVP, where R is redness, S is sensitivity to light, which is also photophobia, V represents vision loss, and P for pain. So that it's very easy for us to remember. Thank you for listening.
Thank you very much, Dr. Bolajoko Adewara, for the scintillating lecture and quite informative. So before we go to the Q&A, I hope Dr. Folajimi is here to speak briefly about the sponsor for the Zoom link that we are using. Okay, while he's preparing, Dr. Dada, will you be able to handle the Q&A now? Let me.
Okay, sir.
Okay.
Good evening, everyone. So we are on Q&A now. Question and if you let me see if you want to ask a question. Please kindly indicate.
Yes, I want to ask one small question. I really appreciate the lecture, and I want to ask whether there are any non-pharmacological treatment for ophthalmic pain.
Okay, thank you, sir.
I offer to you our speaker, Dr. Bolajuku, Dr. Adewara.
Thank you so much for the question. So I think the treatment depends on the etiology. For example, in patients with refractive error, uncorrected refractive errors, they feel more pain the more they stress their eyes. So whenever they rest, for example, if they sleep, they usually have relief. And by the time they wake up, the pain has subsided. So in such a situation, that will relieve the pain. But unfortunately, it's a temporary relief. They will still continue to have recurrent pain until they get the appropriate treatment. So I think that's an example of a non-pharmacological treatment. And then now that many people have a lot of digital devices, of course, it's good to rest the eyes instead of just using the devices in a prolonged manner. Intermittently, it's good to just rest your eyes, look away from your screen, rest your eyes, then you can now go back to your work. But apart from that, I can't think of any non-pharmacological, nothing comes to mind right now.
Thank you very much. There is this connection with migraine and light. Can you say anything about that?
Yes, they usually present with sensitivity to light. It's one of the symptoms of the migraine. So usually when the patient is complaining about headache, pain, and light sensitivity, then we start suspecting migraine. It has to do with the light impulses. I can't, it's a bit complicated, but when the patient presents with light sensitivity, migraine is one of the differentials.
So basically, you brought it to the person who
Thank you.
got rewarded. We went to KFC that.
Dr. Akinwale.
Okay, so Dr. Akinwale, please.
Yeah. Hello, good evening.
Good evening.
Hello, good evening.
Good evening.
Okay, thank you, Dr. Adewara, for the presentation. I want to know, after enucleation, some patients come with what they call phantom eye syndrome or phantom eye pain. So I want to know your experience with this, with the management. Then number two, in anesthesia, when we do nerve block, we normally use adjuvant to prolong the duration of the action of these localized agents. I want to know, do you normally also in the nerve block and eye surgery, do you also add the adjuvant to prolong the duration of action of the agent you use? Thank you, ma'am.
Thank you, sir. So so the first question about phantom eye pain. Well, the eye pain could be so patients that have enucleation can have the feeling as if the eye is still there, but they can also have pain, and that pain is usually what we call ciliary spasm, and is associated with the ciliary body. There is some abnormal connections that result in pain. And it is also associated with the indication for the enucleation, because one of the indications for enucleation is a painful blind eye. So they could actually have developed that ciliary spasm before the enucleation. So after doing the enucleation, they may still have residual pain. And in such situations, some of the options of treatment include injecting cyclophosphamide into the orbit. You can also inject absolute alcohol into the orbit. And then usually the pain is relieved. But what that does is that it completely damages the ciliary nerve. And so they don't feel pain. And then for adjuvant nerve block, I'm not very clear about what you mean, but sometimes when you dilute the anesthetic, it lasts for a longer period. And then, as I said, for surgeries that lasting more than 1 hour, we usually combine short acting with longer acting anesthetic agents like bupivacaine. Thank you.
Thank you very much. Salis Abraham Adam. Salis Adam, you have the floor.
Thank you so much, sir, for the opportunity. And thank you, Ma, for the very concise and educative presentation. I'm Dr. Salis Adam, Senior Registrar in Anesthesia from OE Teaching Hospital. Please, Ma, I want to know your opinion with regards to critically ill patients or patients in emergency in A&E that have multiple injuries, which they may not communicate the eye pain. Some of them you may see swelling around the lids, the conjunctiva may be red and some other features. So is there any tool that you may use to be able to assess whether they may have some localized ocular pain? So that's the area I just want your own opinion. And secondly, the issue of adjuvants that Oga asks about. In anesthesia, we can add some agents like fentanyl, some other adjuvants into our local anesthetic agents in order to prolong either the duration or improve the quality of block. So even the adrenaline is part of adjuvants. So some of those things can prolong either the block or improve the quality of the block so that patient may not have much pain within short period of time. Thank you so much.
Thank you very much. So you are very right. Yes, we use those adjuvants. I think I now understand what he was asking about. And our anesthetics in my hospital, they are very helpful with that. So it depends on the type of surgery that you are doing, because some of our surgeries are quite short. But for prolonged surgeries, we give things like that. But also, it also depends on the, sometimes we need our patients to cooperate with us while doing our surgeries. So in such cases where you want the patient to be able to follow instruction, we always try to limit it to just local blocks. But as you said, we also do, sometimes we even give mild sedatives as well to add to the blocks and to the anesthesia. So we do that. And then concerning accident and emergency patients who cannot, maybe they're even unconscious, who cannot speak, or maybe they have even more severe pains in other parts of their bodies. So the eye pain is not paramount. One way that we can, like, as I said, the cornea is one of the commonest places that is painful. So even if the patient is unconscious and you stain the cornea with fluorescein, it will still pick up the dye. And then we know that there is an injury in the cornea, and then we try to treat. But any abnormality of the eye, whether lid swelling, redness, I think if it's for A&E, then a consult can always be sent to the ophthalmologist on call, and then we come to review. But there have been situations, there can be instances where, due to the severity of the comorbidities, the eye is maybe not given so much attention. And when the patient comes out of unconsciousness, then you find out that they now have severe eye damage and things like that. But as much as possible, if any abnormality of the eye swelling, protrusion, redness is noticed, even things the patient cannot complain of, but can be found during examination, then you can always call on the ophthalmologist to review such a patient. Thank you.
Okay,
Thank
so
you.
I was Professor Sharon, she was raising her hand initially, and I think later. So
Yeah.
let's start with Professor Sharon. We'll still have other hands up. Professor Sharon, please.
Thank you very much. I also want to say that before I ask my question, to our
I guess we have a network issue. So let's take Professor Dolly, please.
Thank you. Thank you, Dr. Adewara, for that very simple and very insightful presentation. I enjoyed every bit of it. And I'm just looking at the okay, Professor Shoyawo is back, I think.
Can you hear me now?
Okay, please go ahead, ma'am. We can now.
Yeah.
Sorry, Ma, your network is really bad. We cannot hear you at all. That's really, really bad. And Professor Odole, continue.
Okay, sir. Thank you, sir. And I was just about talking about what these the SSPN actually stands for in terms of the multidisciplinary component and also the interdisciplinary component. And when Dr. Adewara was actually speaking, she mentioned something about the use of hot compress. There was a question by our president about non-pharmacological treatments of ophthalmic pain. So I was just thinking that, is it possible that we can actually think about hot compress and ice compress in terms of cryotherapy and the use of thermotherapy in the management of ophthalmic pain? I have not done that before as a physiotherapist, but I'm just thinking now that it could be something that we can actually look into if using those cold and heat can actually mediate in ophthalmic pain as a non-pharmacological treatment. Thank you very much.
Do you have patients that develop chronic pain following all the acute pain you described in these patients? Sorry, I'm just coming back with my question. Hello?
Hello, ma.
Yes,
Thank you, ma.
Please go ahead, Dr.
Yeah, my question.
I think we had your question. So you can go ahead, Dr. Adewara.
Thank you, ma. So concerning chronic pain, some patients that have, for example, uveitis can eventually develop chronic pain from the inflammation, the chronic inflammation. I mean, acute inflammation can become chronic inflammation. And that is where we have the entity of the painful blind eye. So in some situations, even some patients with what we call neovascular glaucoma, like it's not only acute angle closure glaucoma that causes pain, because but it's one of the commonest, but there's also what we call neovascular glaucoma, where there's ischemia of the retina leading to new vessel formation, which causes an angle closure, but a chronic angle closure, not an acute angle closure right now. So it causes a chronic angle closure, and this can also lead to a painful blind eye. So we have patients who develop painful blind eyes from chronic angle closure glaucoma and from chronic uveitis. So as I said earlier, some of these patients, we have to eventually remove the eyes, either in form of evisceration or enucleation. But usually, if they are treated promptly in the acute stage, they may not develop these complications. And then concerning the issue of warm compress, I think I hadn't thought too deeply about that before, but I think I'm thinking about it now. For example, in dry eye, one of the causes is also meibomian gland disease, because the meibomian glands, which are the oil ducts in the lid, when they have poor quality, it can become insipated and blocked. So that blockage could lead to what we call meibomian gland disease, which is one of the causes of dry eye. So usually applying warm compress usually gives them a lot of relief. And this solidified oil fat, the warm compress helps to liquefy it and becomes fluid. And sometimes this blockage is relieved. When the blockage is relieved, and then the patient becomes more comfortable and they do much better. So that's one of the instances where warm compress is used a lot. We use it a lot in cases of dry eye. Cold compress is also useful for patients with inflammatory conditions. It helps to reduce inflammation. So we use cold compress in such cases as well.
Okay, thank you very much. We appreciate it. Professor Nwanso, and then after that, Professor Fakonle. So.
Good evening. Am I being audible enough?
Yes, ma'am.
Okay, good evening, ladies and gentlemen. I thank the presenter for that brilliant presentation. I enjoyed it, and especially the illustrations. They were very good. It made it easy to understand all this fluorescent dye and all those things. So thank you so much for that. My own is a question really, because I had this personal experience that I use glasses, and sometimes even after I have done my refraction and got new glasses, I still experience eye pain, which even when you take paracetamol, rest and all that, it doesn't go. What could be done? What could be responsible for that? And what could be done about that? And the second question is, there's somebody that I know that has this persistent foreign body sensation in the eye. There was an accident, and maybe particles of glass and things like that was left, it was in the eye, it was operated upon, but still till date, that is the complaint. So what can be done about such a scenario? Thank you very much.
Thank you so much.
I mean, Dr. Let's just take Professor Fakonle's question so that we can combine the responses. Thank you.
Thank you very much, Dr. Adewara.
Thank you.
Illuminating talk. Let me ask my question. I had already typed it there, but it looks like nobody's looking at it. In our environment, sometimes you have this epidemic of conjunctivitis, which is called Apollo. And many people develop red eyes, watery eyes, painful eye. And they go on using all sorts of things, except things that you have recommended tonight. Some of the things they use include acid water and from the battery of a car, or they go and use cow's urine. Please, can you comment about these harmful community practices on this forum tonight? When you have eye pain, what and what not to use, particularly the non-medical things that our people use around. What can be their consequences? Thank you.
Thank you so much, ma'am. Sorry, please, I don't know if you can permit me. I noticed my HOD's hand was up. Maybe she has a comment she wanted to make. Professor Adewengbe.
Yes, Professor Adewengbe, please, ma'am, or sir.
Oh, thank you. Sorry. Yeah, I dropped my hand because I noticed that some of the comments I wanted to pass are already addressed. But there was a time you asked about non-pharmacological treatments or therapies in cases of eye pain. So I was going to mention a few. I know Dr. Adewara has given us a very brilliant discussion tonight. I want to appreciate her for such a good presentation. With regards to non-pharmacological therapy, some of them you have already mentioned. That was when I dropped my hands. If someone has refractive error and is having pain or any form of refractive problem and the patient is having pain, the best way to relieve that pain, which is non-pharmacological, is to do refraction and give a pair of glasses for such patient. And a question had just come now that even when you take a pair of glasses and keep on having pain, what do you do? Well, for some people who have to change their prescription, sometimes there may be pain following introduction of new prescription lenses. And that should last for about a few weeks, after which the person should be able to adjust to it. If it doesn't adjust to it, then they have to go back, we call it spectacle intolerance, and have the refraction checked and find out where is the problem. Is the glasses okay? Is it the problem with the frame? Is it the problem with the person that prescribed or dispense the lens, because there may be error at the level of dispensing of the lens. So this can be done for the person that has a new pair of glasses and is still having pain. So you may have to go back to the person that prescribed the glasses to you and they will do some tests to ensure that spectacle intolerance that the person is having is something that can be taken care of without in a very short time. Then other non-pharmacological treatment have been mentioned, like use of cold compress for some people, like allergy. We found out that people with allergic conjunctivitis that is having associated eye pain, when they put a pack of ice pack on the eyelids, instead of rubbing the eye during the time they're having itching, once you put an eye pack and wait for some moments, maybe do that 2 or 3 times a day, they may not use much of medication, eye drops, for the allergy. Sometimes the allergy may even wane off and the person may be free from pain associated with ocular allergy. And then if for any reason a patient is having photophobia, use of sunshades is recommended. So sometimes when you use sunshade, it reduces the intensity of bright lights, and so you have less exposure to the light and less pain. So these are common practices that can be. And then there's this method, I don't know whether there is this Chinese, what they call it now, method, which we don't use regularly here, whereby they use this acupuncture. For some people that are having ocular pain, there are some points around the orbit where they think you can put some needle prick and then the pain may be relieved. It's a form of acupuncture. So, and then there are some ocular exercises that can be done as well if somebody is having pain from misalignment of the eye, and the inability to converge, maybe convergence insufficiency or convergence excess or divergence insufficiency. These ones may be too technical, but people with problem with refraction, either from refractive power or problem with alignment of the eye, can do some ocular exercise too that can help them to reduce the pain that may be associated with it. And she has rightly mentioned that if you are working on your visual display system, like the computer and things like that, you may have to take off your eyes from the system from time to time so that you don't get yourself exposed to too much of not inability to blink that may lead to dry eye, and then the person will be having pain. And then for those people with dry eye, apart from giving them artificial tear drops or tear substitutes, you encourage them to blink more frequently and be sure that they don't get stuck, like watching television and you are not blinking as much. People should make conscious effort to blink more frequently. With that, the corneal surface will be wet, and the dryness that can cause some form of ocular discomfort and pain will be taken care of. So a few of these methods can help, apart from use of medication that patient may need, can be very helpful. So those are the comments that I have with regards to use of non-pharmacological treatment for eye pain. Thank you.
Thank you so much, Ma, for those very cogent contributions. Thank you so much. I want to just address some of the questions that were brought up. Though Prof has already alluded to some of them, but just to address the issue of especially because this is a personal experience, so using glasses, obtaining glasses, and then still having pain. One of the common causes of that, Ma, is accommodation insufficiency, when there is poor alignment of the eyes. But usually, it's almost like a special skill. I mean, you have to go the extra mile to check for that. So it's easy to just do refraction and prescribe glasses. But if the eyes are not well aligned and there's accommodation insufficiency, especially when doing near work, there will be so much pain, despite the fact that the refractive error has been corrected. So the refractive error has to be corrected, but the ocular alignment also has to be corrected. And just as Prof said, there are some exercises you can do, like orthoptic exercises, like the pencil push-up, which will help to train the eyeballs to become well aligned. And if there is any, there are different degrees of poor alignment. So usually it's the people who are so specialized in strabismus care that usually take care of such issues. But it is very important to rule out poor ocular alignment, especially when the refractive error has been corrected and you are still experiencing pain. This is one of the common reasons. And then another reason why people experience pain is also dry eye. Like I was trying to explain, dry eye is a very simple condition, but it is very, it is highly underdiagnosed and misdiagnosed. It's one of the most difficult conditions to diagnose just because it presents in masquerade ways. So sometimes you may be feeling pain, but actually you're having dry eye. So until that dry eye is treated, you know, people will present in different ways. Some people will say it's pain, some people say it's foreign body sensation. So it can present in a myriad of ways. But at the end of the day, it will end up being dry eye. So there are some tests that we do to check for dry eye. We look at the quality of the tears, we look at the meibomian gland orifices, we look at the eyelids. And then we look at the cornea, you know, if there are tear debris. There are so many things we look at when we now come to that diagnosis of dry eye. But some people who are using glasses and feel pain during near work is because they also have dry eye in addition to the refractive error. So if the dry eye is not treated, you just know that you are not feeling okay, but you don't know why. And because it is not so many people can make that diagnosis, you may keep complaining and people will look at the eye and say they can't see anything, that there's no problem, you're fine, but you will know that you are not okay. In such instances, it's always important to rule out dry eye. And the treatment is actually very simple. It's just artificial tears, especially for mild conditions. And then also there was the case of somebody who had foreign body sensation. There was glass in the eye. And after that, the patient is still having persistent foreign body sensation. It's almost just the way I try to explain that dry eye can present in many ways. The person may attribute that feeling of foreign body sensation to the accident, but the truth is that that foreign body sensation on its own is a sign of dry eye. So the accident may have come and gone and all the symptoms resolved, and this dry eye is what is remaining. But because of the way it presents, you know, it's difficult to diagnose. So I'm highly suspicious that that person has dry eye as well. So it presents in different ways, in different forms. It's not very clear cut, but it's easy to diagnose. Once you've made the diagnosis, it's easy to treat, and the patients usually have a lot of relief. And then also to Professor Fakmonle's question about using non-pharmacological, all these traditional eye medications, putting cow urine, putting acid, putting cow milk, putting onion. In fact, some people have put brake fluid, battery acid, so many things. Unfortunately, it's one of the sad situations in our environment that these treatments, these self-treatments that people use actually cause more damage to the eye than even the Apollo. So Apollo is a form of viral conjunctivitis and is highly contagious. So usually once you have contact with somebody with red eye, then somebody else gets it, then you keep spreading it and it keeps going around. So usually, like all viral infections, they will always usually eventually subside spontaneously. So usually when they come to us, we give them symptomatic treatments, for example, artificial tears, vasoconstrictors, maybe prophylactic antibiotics, depending on how bad it is. But even if we don't give those symptomatic treatments, we tell them to wash their hands before they touch anything, ocular hygiene, keep the eye clean and things like that. But even if we don't give all those treatments, the viral conjunctivitis will eventually resolve maybe within about 2 weeks. But because of the alarming way that the eye looks red, and everybody's like, your eye is red, your eye is red, and people get so worried, then they now use the easiest treatment they get their hands on, which includes cow urine. Some people even put their own personal urine. We have seen so many cases of patients that have done such things. And some people have even gone blind. I've seen a woman who had viral conjunctivitis put urine in both eyes and became blind in both eyes. And then we also have patients who buy over-the-counter drugs that are not prescribed by an ophthalmologist. For example, some people, when they get to the chemist and explain that they have red eyes, whoever is there sells topical steroids to them. So it's actually topical steroids that they use to try to treat that viral infection that ends up causing damage to the cornea and causing blindness. Sometimes they end up with infective keratitis, corneal ulcers, corneal abscesses, and even endophthalmitis in some cases. So actually, as much as possible, we can educate people in our immediate environment, in our communities, never to use any over-the-counter drugs or self-medication or traditional eye medications. Once the eye has a problem, just go to the nearest doctor or the nearest eye doctor that is in your environment. Usually the drugs they buy over the counter cause more damage than even the viral infection, which is actually very common. So I think we just need to do more health education, more eye health education to people in our communities. But it's actually quite common, but we have to just keep educating ourselves. For very, very valid points. Thank you so much. I think I've taken all the questions.
And basically, there were some requests about your slides. If you don't mind, I will reach out to you now. That's both my phone number and then okay, Dr. Olateju will reach out to you since we are talking about
no problem.
you. Thank you very much for your presentation. I must say again that this presentation has entrenched the interdisciplinary nature and the multidisciplinary nature of SSPN. And I never imagined that I would enjoy something on high this much. So I appreciate your way of presentation as well. Let me hand over to the president as we wrap up.
Thank you, Dr. Dada, for anchoring the Q&A section. And also, once again, thank you, Dr. Adewara, for the excellent presentation and the reactions to the questions. What is left for us now is to encourage people to become members of the SSPN. We are a chapter of the International Association for the Study of Pain, and we are multidisciplinary, cutting across all spheres of endeavor involved in the teaching and research and management of pain. So we encourage those people who are not members. We have our website. You can reach out to us And also, we want to thank our sponsor for this webinar, the ESFA Lab, that has sponsored this Zoom. And I want to thank every one of us that have found time to come. Next month will be another time for another presentation. Thank you very much. And have a good night rest.
Thank you.
Thank you, everyone. Good night.
Thank you all.